And it's my great delight and pleasure to introduce three of our colleagues who are going to give us presentations in the stimulating topic, It Takes a Village, Engaging the Christian Community in Family Planning Success. Christians making a difference. How about that? So without further ado, Lauren Van Enck from the Institute of Reproductive Health will get us started. Lauren? Maybe just go ahead and start.
Yeah, Mona will figure it out. All right, so welcome. And as Douglas said, my name's Lauren Van Enck. I'm with the Institute for Reproductive Health at Georgetown University. And I'm going to be describing a project that we have in Kenya with the Christian Health Association of Kenya, or otherwise known as CHAC, and also CCIH. So in the next few minutes, I hope to describe to you the capacity building strategy that we use to support CHAC facilities, as well as community health workers and religious leaders to provide family planning, and show you some tools that we developed to support the process, and also to present our initial project results. So why work with Christian health associations on family planning? Well, CHAs provide a significant portion of the health services across Africa. You can see in this map all the different countries that have Christian health associations. And while we're not totally clear on the data, it is estimated that anywhere between 20 and upwards of 70% of health services are provided by CHAs in any particular context. So some of the barriers that CHAs have in providing family planning are really related to resource constraints and lack of training. And it should be noted that while sometimes religious barriers are an issue, it's more often than not resources and training that really keep CHAs from providing family planning. So we believe that the partnership that we have with CHAC and CCIH really supports CHAC's vision. And I don't know if any of you were here a couple years ago when Dr. Mwenda came to speak. He's the director of CHAC and also sits as the director of the African Christian Health Association platform, which is sort of the association of associations. And his dream is that family planning, education and options will become easily accessible through a community-based distribution system. And also that family planning will cease to be restricted to hospitals where it is offered as medical treatment, but instead will be transformed into an opportunity for family-centered healthcare. And also that family planning will be a right for every woman and family. So considering the wide reach of Christian health associations and their emphasis on family-centered healthcare, working with CHAC seemed like a natural partnership for this project. So IRH, Institute for Reproductive Health, CHAC, Christian Health Association of Kenya, and CCIH, Christian Connections for International Health, partnered together to get funding from the World Bank for a small pilot project in the eastern region of Kenya. And we introduced family planning at the community level by building the capacity of community health workers and also religious leaders in those project areas. So project activities fell into four main objectives. First, we set out to strengthen family planning services provided by CHAC members. We also sensitized pastors to the benefits of family planning in order to create a supportive environment for family planning information sharing and also method use. And third, we wanted to strengthen the reporting process by offering monthly supportive supervision to community health workers. And finally, develop a capacity building strategy that could then be taken forth by other Christian health associations who wanted to build on CHAC's experience. So the backbone of this project was really the training of community health workers for information and service provision. So we trained 67 community health workers in the eastern region of Kenya to provide information and methods. The methods they were able to provide at the household level were pills, condoms, cycle beads, which is used with the standard days method, and also lactational amenorrhea method, which is exclusive breastfeeding for the first 6 months postpartum as long as the mother's period has not returned. In this project, not only was family planning able to be provided at the community level for the first time in over a decade, but we were also able to even expand the method mix available to women by adding cycle beads. This was the first time in this area that cycle beads was an option for women. So as I said, in our fourth objective, we wanted to develop a capacity building strategy which could be used by other Christian health associations. And the way we went about developing this was to really distill all of the lessons learned from the project experiences and use them and put them in a very digestible format so that other Christian health associations could learn from them and then adapt them. So we came up with 5 essential components for project success, and I'm just going to share with you a couple of the highlights from these components and also the tools that go along with them. So the first is establishing a supply chain. And so we really learned, or confirmed what we already knew, I should say, that no product, no program really rings true. You must take that to heart. So family planning programs are constantly plagued by issues around stockouts, whether they're government facilities or CHA facilities. But CHAs suffer even more than government facilities do. They're often considered secondary and get only the supplies after government-funded health centers do. And they also don't often benefit from capacity building programs offered by the Ministry of Health. And occasionally, CHAs may be able to purchase contraceptives from private distributors in emergencies, but this is very expensive. And also, there's faith-based drug supply organizations that supply some essential medicines to CHAs, but contraceptives are not carried in any of these faith-based drug supply organizations. So stockouts are a really big issue, and it's important that we really learn to get all stakeholders involved from the beginning and begin negotiations with the Ministry of Health before the project even takes place to make sure those supplies are there for the community health workers. And for training, we learned that it's really important to work with an existing cadre of community health workers. Just to increase sustainability, you must work with the linkages that are already there. And many CHAs already are working with community health workers. Oftentimes, they're providing services are related to HIV, TB, maternal and child health, but they're often just information givers. And so if you're interested in having community health workers actually distribute supplies and report on those supplies, it's very important to put in a robust training component that will address that. In terms of the resources that are available for other community or Christian health associations to take forward, we developed a curriculum specifically for the community level, which means that it moves away from some of the lecture-based learning and really focuses on demonstrations and role plays and showcases a lot of the interactive tools that are available. And these are all based on the WHO flip chart. So for those of you who were at the family planning pre-conference, you may recognize this. Douglas showed it in some of his presentations, and it is a brand new tool that is now available on the WHO website in English, French, and Spanish. And essentially what it is it took all of the really scientific information from the cornerstone documents on family planning and distilled it into accessible, digestible messages for the community level and for the clients. And so it's used as a job aid by the community health workers to counsel on different family planning methods. And all of the curriculum and our monitoring and evaluation tools are founded on this WHO flip chart. So thirdly, it was important to establish a reporting mechanism. And this really directly relates to the first component of supply chain. Accurate reporting is so important. If providers are not recording the supplies that they are giving out in the facilities, then the supplies that they then receive from the Ministry of Health will not be sufficient to actually meet client demand. And this was particularly concerning with community health workers because they were new to this reporting mechanism. And also the facility staff were not familiar with collecting reports from community health workers. So it took a lot of communication on behalf of CHAC to make sure that everyone understood their role appropriately. And we also struggled to develop a reporting form that was appropriate for the community level, because the education level and literacy levels of community providers fall across a wide spectrum. And so what we ended up doing was providing a reporting form that really emphasized images to display the instructions so that the community providers really understood what they were supposed to do. The fourth lesson was to create a supportive environment in project areas by reaching out to pastors. And so although CHAC facilities are church-based facilities, they had rarely interfaced with the local religious leaders in those areas. And this project provided a unique opportunity for them to reach out to those religious leaders, to engage them in health initiatives, and to communicate accurate health information to the pastors. It was so successful that they even replicated it in other projects. So we did a sensitization session, and a total of 72 pastors turned up from over 30 denominations to learn about family planning and to understand how they could integrate it into their work and into premarital counseling. And one of the unique tools that we came up with, it was actually written by Judith Brown, who is a CCIH member, is this sermon guide, or not a sermon guide, but a Bible study guide. And so what it has is 7 different passages and questions that go along with it for Christian small groups to study what the Bible says about different family planning related issues and to understand the theology behind it. And it also includes accurate information about family planning methods. And last, we found that it was very important to provide ongoing supervision to community health workers. One lesson that was very well articulated by CHAC was that frontier work is tough. Bringing health services to the community takes an amazing amount of commitment on behalf of community health workers. They receive very low resources and minimal training to be able to address all of the difficult issues that they are seeing face-to-face in the community. And there's often very poor linkages between the community and the facility, which further isolates those community health workers. But CHAC did an amazing job of making sure that community health workers met monthly to receive that support and understand all of the issues that they were going through. And we have several tools to help supervisors. We have a checklist which allows them to understand the agenda of a supervision visit and provide refresher training. And we also have some monitoring tools. One in particular is called the KIT, or the Knowledge Improvement Tool, and it's a simple checklist that can be implemented by supervisors to understand where the knowledge gaps are on the counseling for family planning methods. This can either be used immediately after a training to understand if your training curriculum was successful at communicating the information you intended, or it can be used periodically throughout the life of a project to address the knowledge gaps that the providers have. So by implementing this strategy, we were able to improve the family planning capacity of CHAC and also to increase contraceptive use in the project areas. So let's just take a quick look at what some of those initial results show. These results are taken from the facility in Chogoria Presbyterian Hospital in Kenya, and they are essentially a collection of all of the services that the facility provided, as well as the community health workers. And I just want to point out that this doesn't even capture the entire world of service statistics, because we did have difficulties with our reporting mechanism. So not all of the community health workers' statistics were able to be funneled up to the facility. But even with the ones that were captured, we still showed dramatic positive improvements. So this compares January and February of this year to January and February of last year. Pill use, as you can see, increased over 2,000 users from last year. Cycle beads over 300. And then even methods that are only available at the facility level. Injectables increased over 100 users. IUDs were 11, and implants were 12. So we feel pretty confident that the community health workers were successful in providing the methods in the community, but also in raising awareness about family planning and successfully referring women to the health facilities to get methods that they could only receive in the facility. So to sum everything up, we really learned that no product, no program is so important, and it really needs to be well understood by everyone involved. And this could not be more applicable for a community-based program where the community health workers really rely on project staff and facility staff to make available those supplies.